Hello, everyone. It is my absolute privilege to welcome you back for this final interview with Dr. Carter Thorne. We have had so much fun and learned so much through the hashtag #CArthritis broadcast booth. And again, I feel like every time someone comes in and you're a CRA member, I need to thank you for openly inviting us in as patient partners in your work. To bring forward to the Facebook and Twitter Live community, Carter, the great stuff that not only the organization is doing, but also individual members who not only treat patients every day, but also push the science of musculoskeletal care forward in their daily lives to help people like me and the millions we hope that are watching. So welcome, everyone, and welcome, Carter. Carter is a clinical rheumatologist, you're a clinical trialist, you do all kinds of super cool research. You have a very storied career, but I think where I wanted to start our conversation is really around the work that you did before anybody else did it. And that was to create and build a clinic that truly became a home for your rheumatology patients.
Indeed.
You know, they felt the heartbeat at the arthritis program in Newmarket. And I think we still hear from patients every day, almost, from your neck of the woods, rave about the care and the quality of care that they receive there. So share with our audience why you started that way. What was the inspiration for that?
When I was a medical student,
Yeah.
I had my experiences in rheumatology, which were not all that exciting. And
It's true confession time.
Fortunately, I love it. In my first year of internship at that time, which was 1981, I had the serendipitous opportunity to be on the rheumatology service at Wellesley Hospital in Toronto. Wellesley Hospital at that time had a 40-bed rheumatology unit. It was phenomenal. It was the largest center in North America,
really
dedicated to this, and associated with that particular unit was also what we call wet bench research, down on the first and second floor.
Okay, so that's like basic science.
Basic
type
science,
of work. Yeah.
exactly. And so we had marriage of clinical, and I just said, wow, that's really cool. Now I get it. And I also had the unusual opportunity to spend my whole 2 years there. At University of Toronto, people moved from hospital to hospital.
I see.
And I guess people said, oh, you can stay. And so I developed a relationship with therapists. And surprisingly, I didn't speak very well at that time. I was kind of scared and jittery. But they engaged me, and they said, you know, you look like you can do a good job. So I started talking to patients, people who had arthritis. And so I stayed at Wellesley for 2 years. I was the chief fellow. And it was my sense at the end of that 2 years, I did not want to sit in an academic environment. So I went north. Some people thought, too far north. It was way over there in Newmarket.
Yeah.
However, when I left Toronto, I still had a belief that actually you should have therapists working with you to work with patients to do a better job.
So all of those things that you had in the big city,
and I
Newmarket.
thought it was just what you needed.
Yeah.
So I wasn't contaminated by a sense that, oh, you can't do anything.
Yeah.
My belief is can do.
Good
right?
for you.
It was can do. So I was also fortunate that the hospital I went to, which was York County Hospital at that time in Newmarket, now called South Lake Regional Health Center, had a group of folks that were pretty welcoming. They thought that people like me were assets. They weren't cost centers.
Yeah.
And they said, oh, that sounds like a good idea. And I was actually working in a group where I had to convince a number of people, because therapists in general, we weren't a small hospital, but general hospitals, were to be generalists. And I was saying, I want to train therapists to be experts in arthritis care. And we got some traction there. And then in the mid-'80s, we were working with the hospital to try and secure some funding. And we had a patient, and her husband, who had the connection. He says, I'd like to help you. And this was before we had a district health council at that time, so we could go directly to the assistant deputy minister.
Wow.
And 5 years later,
that's how long it took
to secure funding, and we got the notice, and we got the funding to develop a regional inflammatory arthritis program. And we celebrated our 25th year a couple of years ago. And from that program, which was to be a regional program for inflammatory joint disease, we then developed a more holistic, complete program.
Yeah.
So in that evolution, I learned a heck of a lot from the therapists I worked for, but also from the patients we worked with. And one of the things I learned from one of my favorite mentors, which was Daphne Gladman.
Yeah.
I was one of
Saw
her,
Daphne actually at the poster session today.
and she taught me to count. Counting is very interesting, eh? We all think we count, but she taught me to count in a systematic fashion and to apply that counting to outcomes. So I was very much always outcome-based. I did that of a sense of necessity for caring for patients, but also a sense of necessity for ensuring the success of a program. I always felt that the arthritis program, TAP as we call it, was always going to be at risk for closing. And so our strategy was always to be strategic, to demonstrate administrative outcomes, but more importantly, patient outcomes.
Yeah.
That was a very unusual aspect in those days in the 80s and 90s.
Yeah, boy, I can say that it was.
So that when hospital accreditors, every few years, hospitals have to be accredited, would come around, they'd say, oh, clinical outcomes, there's something novel. So we were the first program in any hospital, in any place.
So you made the hospital look good. This
That's
program
right.
was kind of
So
like a jewel in the crown.
So we did that in an intentional fashion because it was the right thing to do. It was also intentional because it then put you at a higher profile. And then we were able to provide more service.
Yeah. And it helps to keep secured funding in place, I would imagine.
As best as we can.
Yeah, yeah.
And so it's important for people to realize that this is not something that dropped in our lap. This was a significant activity between myself and the team that we developed.
Yeah.
And one of the things I also learned is that we're stronger together, right? And so we engaged people who had arthritis from the very beginning.
Yeah.
We engaged our therapists not as my servants, but as our equals.
Yeah.
So we went from a group that had a number of therapists working with us to a multidisciplinary team to an interprofessional team before we actually knew what that word meant. Someone said, oh, there's interprofessional teams, and they said, oh, that's what we do. Didn't know that's what we called it because we weren't academic in that fashion.
Probably better you didn't know the buzzword,
that's right.
You just did it.
You know, we did it because it was right.
Yeah.
And how did we know it was right? Because we counted.
Oh.
And so that the next iteration was to participate in, as you mentioned, controlled trials, clinical trials.
Yeah.
And from clinical trials, we learned about other things to measure.
Yeah.
Patient satisfaction, patient-reported outcomes, in a systematic fashion, not because someone told us to do it, but because it made sense.
Yeah.
Because it helped us understand how patients did.
Yeah.
And curiously, when you do that, patients actually do better. We also learned about what people are looking for. And we do exit surveys, which sounds very administrative, eh? It sounds very kind of weird.
It's what they do at the polls. It's what they do after a movie premiere,
and
actually.
So we said to people, what did you like about the program? Because we always get, one always gets positive responses when you touch them, when you understand them. What we understood, what they said they got most out of our program was hope.
Interesting.
And hope is an important, we believe, is an important message. Because what you feel, what a person feels when they develop our sense and from understanding and speaking to our patients over time, is that they're devastated. This is something that's come upon them. It's not a lifestyle choice. It's not something they can blame on anyone, or themselves included. It happened, and how can we change that? And our position and our message was always one of hope, and that then drove them. And by continuing our development of outcome measures, good clinical practice, treat to target, we were able to demonstrate that what we did was making a difference, but we were moving forward, because we said that was good, but not quite good enough. How can we push it?
Yeah.
And we also fostered within our team a sense of adventure and inquiry.
Yeah.
So we had, she's still around, but she's retired, a pharmacist who said, we're doing a good job, but our people are having trouble with the medication, in this case methotrexate. I think we can make it better. I'm not sure what it is, but I think we can make it better. And so we do a number of different things to allow people to do well.
Yeah.
And then subsequently, after we've moved out of doing the randomized controlled trials, which are important parts of care, but we had to abandon them because our patients were doing too well to go into trials.
Yeah, they were all stable on therapy.
But we didn't abandon the concept of measurement, and now a measurement that went beyond that.
Yeah.
So now, and for some years, we've done measurements that can make a difference to how I look after the person sitting in front of me, how we can use the measurement to look at the group of people that we've cared for in a period of time. And then subsequently, how do we know we're doing a good job?
Yeah.
Because I only know about the people sitting in front of me.
Yeah.
And so now our emphasis is on doing practical trials, what we call sometimes observational trials, and cohorts. And we have been very successful at that, at enrolling people in clinical cohorts.
Yeah.
In this case, we do cohorts in early inflammatory arthritis, rheumatoid arthritis, established disease. So of the 960 patients that have rheumatoid arthritis in my practice, 420 are in a cohort.
Wow.
Which is a tremendous amount.
It is.
And then we also learn that it is best to treat everyone as if they're in a cohort. That is in terms of measurements and such things. So it's embedded in our ethos, in our culture.
Your daily practice.
In our daily practice.
Yeah.
So when you embed measurement in practice, then you can quickly be nimble about changing.
Yeah.
So that one of the things that I get joked about is the way we manage and use medications and how we do things. And we're able to achieve remarkable successes with legacy medications applied differently.
Yeah.
Applied in a timely fashion. Some people call it aggressive fashion. We call it optimization of care. And we have outcomes which are remarkable.
Yeah.
So we believe that our successes in say, rheumatoid arthritis are based not only in the medications we use, but also how we use them, but more importantly, how people use their medications.
Yeah.
And our adherence rates from studies that we've done within our own population are much better than are advertised in other circumstances. Our ability to maintain a person on a course of therapy that they began at the beginning is remarkably robust.
Yeah.
Additionally, we believe that our people that had arthritis actually have other problems associated with it. So our program has also been to develop programs related to arthritis care. So we call TAP Now, the arthritis program, not a care program for people who have inflammatory joint disease, but we call it a portal of care, portal of musculoskeletal care. So whatever you got, we'll help you with.
Fantastic.
So that you may, and we now know that when I first started practice, the average age of a person was 35, young female, childbearing age, that's the classical thing you read, and now we know it's 55. And so the needs have changed, comorbidities, and so in our program we have pharmacists who are consulting pharmacists. Their only job is caring for people who have arthritis. And we have people who have rheumatoid arthritis who are doing very well, but they have now new pain.
Right.
Osteoarthritis.
That's me.
Yeah. So that our people that have gone through the inflammatory program now go into the osteoarthritis.
But yet they don't get cleaved off and thrown
That's
out the
right.
door. They get to
that's
stay.
Right. That's not my business. Your inflammatory arthritis is okay.
Yeah.
And so in that same evolution, our hospital is in Ontario, the Ministry of Health is mandating that before you have your knee or hip replaced, you have to go to a joint assessment clinic. This is to triage and hopefully reduce waiting times. By the way, we have the best waiting times, or the least waiting times of anyone in Canada.
The best non-waiting times.
That's right. Yeah. But in terms of this, in the TJAC model, Total Joint Assessment Clinic, you go in, they say, you can have your joint replaced or you can't. If you can't, have a nice day. In our system, TAP is going to be doing this for our orthopedic colleagues because we are joined.
Right.
We have a program integrated. They will come and they'll be not appropriate for surgery. We have a program for you.
Yeah.
You have pain. It's a chronic disease pain, fibromyalgia or whatever.
Yeah.
So we have a chronic pain management program.
Yeah.
By the way, you broke your hip as well because you're in that age group. We have an osteoporosis workshop. So it's holistic.
Yeah.
And you stay within the same, not bricks and mortars necessarily, but kind of, and you're still receiving the care. And the other component is that you don't come to us to receive care, you come to us to learn how to accept care. And so it very much self-management, self-empowerment.
You know, I'm sorry, but your inbox is going to explode with the thousands of patients who now want to be part of the TAP program, which I kind of expected. You know, and I know you've been a pioneer as well in this whole early arthritis clinic concept, where people who present quickly with inflammatory signs and symptoms, the fatigue, 5 active and swollen joints, some of the other complaints, morning stiffness lasting greater than an hour. For you in your practice, that's a medical emergency.
Absolutely.
Yeah.
I was struck. I participated in a multinational program in the late '90s, early 2000s. And so it was a multinational, and they were talking, they just inquired, raise your hands, when do you start therapy? And on average, it was about 3 months after a diagnosis. What the heck? What's the deal here? Why would you wait?
Why would you wait?
To your point here, and I said, gosh, we don't have to wait because we have a team that supports.
Well, and it explains the need for early intervention.
So what happens, what we hear from colleagues who do not have access to a interprofessional care team as we have, the people I meet are so frightened I can't present to them the information right away. And to your point, is that what you do when you find a lesion on a lung, chest x-ray?
Yeah. No,
is that what you do when you find a lump on your breast? You deal with it today because that's when you have to deal with it.
Yeah.
And the person came to you with an issue, and we will deal with it today. So in our early arthritis clinic, as we have it, you come in, you've been triaged by our advanced care practitioners. We make the decision, you go and see the pharmacist, and understanding that there's a lot of information provided.
Yeah.
We then make a decision what we're going to do today, which may or may not be methotrexate or Plaquenil, whatever we do. We do whatever else is going to be done. We then develop the program. You'll then be seen within another week or two to make sure that you've integrated, that you've started your therapy.
Okay.
I don't have to see you because I have a reliable, high response team that is able to be my surrogate.
Yeah.
And that can then call upon us.
Yeah.
And then we can have this to and fro, targeted therapy, as you said. And targeted doesn't necessarily mean using new therapies. It means getting you to where you want to be quickly.
Yeah.
And so our expectations is from anything we start, whatever we start, you will be 50% better in 6 weeks.
That's just amazing. And such a sea change, as you say, not just then, but even now.
Even now.
Carter. Yeah. We hear about delays, and oftentimes it's not the delay necessarily to start the treatment once you're seeing the rheumatologist. It's actually the public and patient as public who understand what it is they should be saying and
Yeah.
describing to their family doctor in order to get to you.
Well,
and there's a gap there.
Yeah, indeed. So, one of the important referral kind of patterns is people talking to people, right?
Yeah.
And asking. So we'll actually see, our arthritis program is not restricted to the 4 rheumatologists. The access, I should say, is not restricted to the 4 rheumatologists in Newmarket.
Yeah.
Anyone who's referred by a physician, and in the healthcare system they have to be referred, but they can be referred by their family physician or a rheumatologist external.
Okay.
We still provide that they get the same level of care. We feed back to the primary care physician and or primary care rheumatologist so that the continuity, the circle of care continues, and we ensure that the care is undifferentiated. It's agnostic to who you'd live with.
Yeah. I've known you a long time, Carter, and I'm going to go not out on a limb and say I think you love what you do as much today as you did 20 years ago.
Well, I'm just, the changes that are occurring now, I think in terms of personalized medicine, precision medicine, I think there's a lot for us to learn. And the presentation by Dr. Thomas in terms of vaccinations and things, I think she did put a proviso on it. But as I've heard some of my colleagues speak of, the fact that we are now able to learn so much more about patients.
Right.
And I remember we did genetic studies with my colleague, Dr. Siminovich at Mount Sinai, and she would do one cell thing when they do whatever measurement it is, and it would cost $1,000. Now it's 1,000 wells, and it costs $10.
$10, it's like that mass throughput.
And it's just phenomenal how we can now move forward, utilizing it. And I know that we both recognize that some of our other specialties, especially cancer, have very personalized things. They can say, if you have this profile, biologic profile, no wonder the medications didn't work before, because you were the wrong person for that medication.
That's right.
And we can do that kind of by proper counting, proper identification of a person. And when people talk about bad prognostic indicators, I don't see that. I see a person who has a need, and the urgency of that need is mandated by those markers. By those markers, but not the success of therapy.
Yeah.
And our objective, our target, our goal is the same for every individual who comes through. That you will be free of discomfort and back to where you were before this all began.
Well, I'm telling you, I'm singing from your gospel book from here on in, buddy. The energy and the passion for the field of rheumatology and the pioneering work that you've been doing in Newmarket and spreading the gospel to all of your colleagues nationally is so appreciated by the patient organizations that have partnered to bring the Arthritis Broadcast Network and See Arthritis #project to life. Arthritis Consumer Experts, Canadian Spondylitis Association, and the Arthritis Patient Advisory Board of Arthritis Research Canada. We're very thankful for all that you're doing for the patients that we represent who hang out with you in Newmarket and beyond.
And what the Arthritis Care Network does as well. It's fabulous. The kind of stuff, I get your emails on a regular basis. I share them with my patients.
Fantastic.
The bulletins go out on the display. I think it's really important to have robust representation from providers, from patients.
I think we're part of the team. We're part of the team that you've built and that other rheumatologists have built. So thank you very much. We're going to go to our audience and see if there are any questions before we wrap up and let you get on to, I think, what is the banquet tonight.
Dr. Carter mentioned that you have the best waiting time. Can you define what is the best waiting time?
Good question.
So there was a Wait Time Alliance program that was developed through the Canadian Medical Association, and some of these wait times were based on some other factors, some other objectives, and it was really initially built around getting an MRI, getting hip replacement, and things like that. So we were asked to participate in developing wait times. So what we did is engage one of our members. This is when I was president of the Canadian Rheumatology Association. And we did a survey of our members and reiterated it to different iterations. And it was determined that a person who had features that suggest inflammatory joint disease should be seen within a certain period of time. And this was not evidence-based. It was eminence-based,
right.
expert-based. And so these guidelines were established before we were doing what we were doing.
Before you started counting.
Before we started. No, we were always counting.
No, but
before,
in that regard.
In that regard.
Yeah.
And so this was a retrospective that was done through the CATCH cohort
Yeah.
that we participate in. So this CATCH cohort has been very informative to us in helping us improve our care to people who have arthritis. And coincidentally, we were able to achieve that target 50% of the time, even though we didn't know what the target was.
Right.
And the rest were shortly thereafter. And usually the challenge was that when they were first seen, the disease evolved, so that a diagnosis that was less clear, because our team is a high-end team. Every year we have a round robin where we test our own skill set.
Yeah.
Don't test the therapist. We test all of ours. The doctors, the therapists, and the nurses.
Yeah.
They're all tested against the same standard.
Wow.
And so we do that.
So when a patient gets referred to TAP, how long, when you say good wait time, how long is a patient waiting? Not to put you on the spot, but just...
So we have now we have electronic records, so it's easier to move things. In my case, all the things that sound inflammatory go to TAP.
Yeah.
And our early arthritis clinic is within TAP, so that when they're seen, then they can be shifted
moved
around within our team. So that now that referral is done within 48 hours to TAP, and then if they're seen as with enough information to identify them as urgent, they're seen within 7 days.
Wow.
7 to 14 days.
That's breathtaking.
And if they're seen and triaged by the allied health professional as urgent, they call me up, or one of us is always on site, or my colleague sees my patient. Like, it doesn't make any difference to us. It's what the person needs on that date. So we'll frequently get a call, got your patient, they're pretty active, send them on over.
Wow. You know,
to that emergency point that you made, it's not
and
like it's too late now. I gotta go. You know?
No, and I have to say that kind of it's consideration actually of the concern and the worry and the true physical discomfort that patients are in early in their disease, and uncertainty. What we really want addressed, almost more than our symptoms sometimes, is to achieve a diagnosis. And so
absolutely.
That quick turnaround is so critical.
And to demonstrate that we can achieve a return. And I use
to normalcy.
I use this phrase that Maxime Dugadas, one of our eminent researchers in France, used. It's good to feel better, but it's better to feel good. And we're going to get you to feeling good, which means where you were before this began.
Thank you. That's wonderful. Anita?
Another viewer wants to commend you and your team on your continuum of care and the great work that you guys do. But she's wondering, for your inflammatory program, how does the funding occur? Is it higher than for the rheumatologist on his own? And is the money for the team or per patient?
Oh, okay, good question.
Yeah.
So our original program establishment was going to the deputy minister, and we got an annual grant that came to the hospital. It was designated. It could not be used for
TAP.
For TAP. Yeah. So it was $325,000, something of that nature.
Yeah.
And so that was, then there had to be administrative and other milestones that were met over a period of 5 years or thereabouts. And after that, it rolled in. So now we were subjected to the possibility that the money, and during that time, if the hospital said, you're gone, well, the money was gone too.
Oh.
So after that, when it was rolled into global budget, now it was exposed to other stresses, as it were.
I see.
And again, being very strategic, as you know, you have to be strategic.
Yeah.
We tried to make ourselves such a beacon of excellence that it would be hard to say you're gone.
Bye. Yeah.
And especially, when the accreditors came every 3 years or 5 years, whatever it was, and said, that's a key program. It's hard to say that key program, because we're not an expensive program in the budget of a hospital.
Yeah.
So to answer the questions of the viewer, we are paid through the Ministry of Health in the global budget of the hospital. There are fees from time to time, so when you go to one of our programs, we have a very excellent summary booklet that people take away with them, and there's a fee for that. It's $50, but that doesn't exclude you. If you can't afford that, there's no one that is excluded for that.
Yeah.
It's to help defray, but it's as we do. When we establish new programs, so we were originally funded to do the inflammatory program.
Right.
We saw a need for osteoarthritis, so we partnered with the pharmaceutical industry with an agreement with the hospital. If we met milestones, targets, targeted outcomes, both administrative and otherwise, that they would continue to fund.
Okay.
But in general, we were able, because of the efficiencies that we were able to establish with group therapy before there were such things as group therapy, that we were able to fiddle it within our budget. And then we developed a fibromyalgia program. And then we developed an osteoporosis program in partnerships with other groups. And trying to, as best as possible, look at resources that are available. So we do a lot with what we do.
It sounds like you do a lot with a little,
With
actually.
Yeah, indeed. So it does require the attention and the collaboration of an allied health professional is also an administrative person, so they have to be pretty skilled at that piece. Because the physician has to be, and the physicians in our case for TAP, have to all be on side and make use of a program. The therapists and all the team have to also pull together so that we have, though we have, quote, people say Cadillac service, which we say is actually essential service, we also have the best work productivity. So that when you look at it, because they have these workload measures, so we can demonstrate to the hospital, we are not an expensive program for the number of lives we touch. So these are all parts of understanding the system and working within it to optimize our results.
It's amazing. It's at top to bottom, just an amazing program, and it's not a surprise it's amazing because you have the amazing Dr. Carter Thorne as its fearless leader. We can't thank you enough for joining us.
My pleasure.
It's always a delight to see you. It's always a delight to speak with you and learn from you. And we really appreciate you sharing some of those inner workings of the TAP and how it came to be and how it's grown and how it's actually pushed clinical care in Canada. So thank you very much, Carter. Appreciate it.
And thank you for inviting me to, again, share my experience with your audience.
Always, always.
Thank you.
Have a great rest of meeting.
Thank you very much.
Yeah. Thanks, everyone.